Hi, everybody. My name is Milka Koupenova. I am an assistant professor at the University of Massachusetts Medical School, and my lab focus is on respiratory infections, including SARS-CoV-2, and how they relate to immunothrombosis.
And I'm Eduardo Marbán. I'm the executive director of the Smith Heart Institute at Cedars-Sinai Medical Center. Milka and I had the pleasure of moderating a session on COVID-19 and cardiac manifestations thereof. And we wanted to just chat with each other having finished that session. Basically, we reviewed some aspects of the pathology, the clinical manifestations, the clinical implications. We also heard a little bit about how some specific protease activity might modulate some of the sarcomeric proteins. So Milka, what did you take home in terms of the pathology, the talk by James Stone?
So I really enjoyed his talk, and I appreciated the fact that he clarified a lot of the questions that many people in the audience often talk about when it comes to presence of infection in cardiac muscle post-autopsy. And I think it is very convincing that there is a presence of viral RNA in the heart. As he mentioned, it is still unclear to me if how infectious this viral RNA is, but by clinical perspective, I guess we call viral RNA infectious. What's interesting to me that it's quite rare. It's not found in that many cardiomyocytes. It is in fact, rarely found in cardiomyocytes. It's more present in interstitial cells, but that is also not that often. And it's found in some endothelial cells. So I don't know what you think about that, Dr. Marbán, but
yeah,
I found
one of the interesting paradoxes is that you can take some of these cells ex vivo, iPS-derived cardiomyocytes, for example, and they're great substrate for viral entry and replication, and yet in vivo, as you mentioned, these are needle in the haystack events, and sometimes when you find RNA associated with a cell, it's really just viral fragments, not necessarily a competent virus that can actually replicate.
Yeah, so I think it's an important thing. What's clear to me is that there is an inflammation, right? If regardless of if the virus is infectious or not, the presence of the viral RNA is associated with increased lymphocyte, macrophage presence, increased inflammation. I think he also mentioned that it was associated with atrial dysrhythmia. So these things are quite fascinating. Inflammation definitely is the outcome and etiology of this particular infection. How much of infectious virus we see, though, it's going to be
there's a real ascertainment bias to some of these pathology studies, or many of them, because they tend to be the fulminant cases that went to autopsy, whereas we're not seeing that, thank goodness, as often as we did in the first waves of the pandemic. But still, cardiac involvement seems to be very prominent. One thing that I found interesting about Ludwig Wakeback's talk in that regard, since he's also doing pathology, but correlating the pathology with magnetic resonance imaging, is that in cases where there's demonstrable pathology, sometimes there's very little cardiac dysfunction and the volumes of the heart are normal, the ejection fraction is normal, and yet there are subtle abnormalities indicative of myocardial edema and abnormalities of circumferential strain in the heart itself, which leaves us in a bit of a quandary as to what to do with that information, doesn't it?
Yeah, and interestingly, he, contrary to Dr. Stone, did not find any viral RNA in the heart. Now, we can always argue that it's perhaps if it's like 1 in a million, it's hard to detect. And methods of RNA detection are also quite important from like basic science perspective. But it's quite fascinating how there are differences. And I often wonder, and I don't know what your take is on that, Dr. Marbán, if this happens only in super severe patients, because those are the patients that go to autopsy, right? If this is a common outcome at all.
Yeah, certainly the longer the disease and the worse the disease, the worse. What I took from the talks collectively was the worse the inflammation, the more macrophages, the more lymphocytosis in the tissue. But what I found interesting about the talks about MRI is the fact that even in relatively mild cases, there are detectable abnormalities. One of the things that Wendy Post emphasized in her talk is that if you look for abnormalities in patients, for example, who have had often asymptomatic COVID, but are athletes, and the question comes up, are they safe to go back to heavy exertion? You can find these abnormalities. And so she is recommending a more pragmatic view, at least now in outpatients, to really restrict that level of imaging to patients who have long COVID and are severely ill and just can't get over the disease, because we might otherwise get information that reveals some kind of subtle abnormality, but we don't know what to do with it, and it's of unclear prognostic value.
Yeah, I agree with that. I think it's a great approach towards the situation, particularly when it comes to healthy individuals that may not even go for too long.
What did you think about the whole thing with the discussion of myocarditis after vaccination for COVID?
So this question continues to occur as we are all into this vaccination mode, and some people believe, some people don't believe, some people are stressed, some people are crazy about it. And I think it's super important to underline what Wendy actually stated, that it is super rare when it comes to the mRNA vaccines. It's not present, but I think she pointed out that it is about 12.6 cases per 1 million that myocarditis occurs into these young individuals, which are predominantly male, which is another interesting thing. And I don't know what your take is on the occurrence of myocarditis stratified by sex. How do you have any take on that?
No, I don't. And it's interesting. The observation is robust. These tend to be young, relatively healthy men, young men who get the post-vaccine myocarditis. It's very rare. The incidence is probably 2 or 3 times that of the natural occurrence prevalence of myocarditis in that young population. So it's, we should be careful not to overstate it. But the other good thing about it is that, with the exception of a couple of cases that get hospitalized or have gotten hospitalized in her series, she finds that most of them recover without much in the way of long-term sequelae after the myocarditis associated with vaccination.
Which is quite reassuring when you think about it, right? Because
it is absolutely reassuring. I know your own work is having to do with platelets and how they're susceptible to viral infection or secondary effects of viruses. How do you think that relates to some of the myocarditis, if at all?
So, I mean, it is interesting, and actually, James Stone showed that there are microthrombi in the heart muscle, which was very interesting to me. And we found that in platelets from patients, no matter how many days post first qPCR, you find viral RNA in these platelets. Now we sequence the virus, and you can tell that the virus is chopped off. Now platelets don't have a nucleus, so it's not an infection defined by giving a productive virus. But I often wonder how much of this gets transferred as platelets are circulating. They become exhausted from dying from that matter. They're hyperactivated. They secrete extracellular vesicles. All of that would affect the environment. So if it's not controlled and it becomes out of hand, I think that's a problem. Now we're going back to nanoparticles that are carrying the mRNA, right? So it's just the spike. And I keep thinking that this perhaps is more of an effect of antibodies coming into play. And we know that antibodies actually can activate platelets through the Fc gamma receptor 2. So it could be that in certain people, depending on expression of certain receptors, they become more activated. And that leads to inflammation into the surrounding vasculature of the heart. It's a possibility, but I don't know for sure. It's quite fascinating. We know that with the other vaccines that have a viral code, then that's more easy to explain. But with the mRNA, continues to be a mystery. It's interesting.
So, pivoting back from the vasculature to the cardiomyocyte, we heard an interesting talk from Nora Yusel from Sultan Irani's lab. What did you make of that?
I liked her talk. I thought it was very interesting of how SARS-CoV-2 is actually able to encode a protease in one of its viral genes. It's called ORF1, which is termed a non-structural gene. And this protease is active. And by this algorithm, they figured that it targets the M-line sarcomere protein obscurin. And they did elegant experiments to show that if you overexpress the protease, obscurin gets dissoluted from the sarcomere. And also, if you infect the cardiomyocytes with a high load of virus, that is about 5 infectious particles per cardiomyocyte, which I don't know if it could happen in vivo. But again, the phenotype that they are observing is happening, meaning that this protein part of the sarcomere becomes dissoluted, and it has a profound structural phenotype in the cardiomyocyte, rather dysfunctional. So it will be interesting to see if this truly occurs in vivo. I'm not sure. What do you think about it?
Oh, it's coming back to our earlier discussion of the paradox, how easily this infection of cardiomyocytes occurs in vitro as opposed to in vivo, where it seems to be quite rare. So the session I thought was great. What are some of your parting thoughts on it, Milka?
I think it's important to realize that this virus is not a joke, and to echo the review that you wrote at the beginning, co-authored at the beginning in Circ Research about stages of infection and how we should think and treat patients. It's complicated, right? The take-home message is there is quite high inflammation in the heart. Regardless if the virus is infectious, it clearly there is a infiltration of lymphocytes and macrophages that shouldn't be there, and there increased amount of inflammatory markers. The important thing, I think, is that regardless of of the vaccine that you should be taking a vaccine, because from everything that we saw, it is not comparable. The myocarditis that occurs in these very few patients is not comparable to the amount of myocarditis and to the levels of damage that COVID-19 can cause. So my take-home message in summary is there is an inflammation, it is not good, and we should be preventing it as much as we can and never get to the point that we will have to deal with the outcome of the infection. But how about you?
No, I agree completely. It was a real pleasure co-moderating this session with you, and I look forward to hearing some more interesting science in the rest of the conference.
Me too. I completely agree with that. I can't wait to see what else is going to come from this lovely BCVS, and maybe soon we'll be doing this in person.
I hope
hopefully. So. But thank you for co-moderating with me. It was a great pleasure.
Okay, great.